All right, let's jump right in. Today, we're heading into the emergency department for a scenario that is every doctor's nightmare, a child whose airway might be about to close. The next few minutes are absolutely critical, so let's break it down.
So, it all starts like so many of these cases do with a patient who is very obviously in a lot of trouble. Let's meet him. Okay, picture this. A 6-year-old boy is rushed in by his parents. Right away, you know something is wrong. The clock has officially started ticking. Now, at first glance, the story sounds pretty standard, right? Fever, sore throat, we hear that all day long. But what we see next tells us this is anything but standard. This is where the alarm bells start ringing, loudly. These aren't just symptoms, they are massive red flags for a closing airway. He's drooling because it hurts too much to even swallow his own spit. He's sitting upright, leaning forward, what we call the tripod position, because it's the only way he can physically keep his airway open. And then you hear it, stridor, that awful high-pitched whistling sound every time he breathes in. That is literally the sound of air fighting to get through a blocked-off pipe.
We know this is bad, real bad. So now it's time to play detective and get some hard data to figure out exactly what we're up against.
First up, his vitals. His heart is just hammering away at 130 beats per minute. That's way too fast. His body is screaming that it's under an incredible amount of stress. And his breathing, it's just as frantic. 30 breaths a minute. He is working so hard for every single gasp of air. This is true respiratory distress. And, of course, the fever. A temp of 102 confirms what we suspect. There's a major infection driving all of this. And this chart, wow, this really tells the tale. This is his white blood cell count. You can see the normal upper limit is about 15,000. His is cranked all the way up to 18,000. His immune system is in an absolute all-out war against whatever is attacking him.
Okay, so we've got the story, the physical signs, the vitals, the lab work. All the pieces are pointing to one scary conclusion, and a single picture is about to confirm it.
And there it is, the classic straight out of a textbook finding. On a side view x-ray of his neck, you see what we call the thumbprint sign. It means his epiglottis, which should look like a thin little leaf, is so swollen and inflamed, it literally looks like the tip of a thumb.
That thumbprint sign confirms the diagnosis, epiglottitis. Let's be clear, this isn't just a bad sore throat. This is a severe, fast-moving bacterial infection of the epiglottis, that little flap that's supposed to protect your windpipe. When it swells up this big, it can completely seal off the airway. This is a 5-alarm fire.
So we have our diagnosis. No more guesswork. In a moment this critical, the very first thing you choose to do can be the difference between a good outcome and a tragedy. And that brings us to the big question. You're standing there looking at this sick kid. You know what it is. What is your single most important first move? Here are your choices. Do you hit him with IV antibiotics, try some oral steroids, immediately intubate to secure the airway, just watch and wait, or give him some nebulized epinephrine? All of these are tools in our toolbox, but only one is the right first step. All right, time is ticking, so let's cut to the chase. Here's the right answer, and more importantly, the reason why it's the right answer. The correct initial move is A, intravenous antibiotics. Now, I know what you might be thinking. Wait, his airway is closing. Shouldn't we stick a tube in him first? That's a totally logical thought, but let's look at why antibiotics take priority here.
It all comes down to this. The swelling is the symptom, but the disease is the bacterial infection. You have to treat the root cause. You have to start killing the bacteria immediately with powerful IV antibiotics to stop the swelling from getting worse. What about the other options? Well, you have to be ready, and I mean ready, to intubate if you need to, but it's not the first step. Nebulized epinephrine, that's for croup, a totally different illness. Steroids, not the heavy hitter you need right now. And sending him home, well, that would be catastrophic.
So the big takeaway here is really this. Managing epiglottitis is a 2-track mission. You launch an all-out assault on the infection with antibiotics, and at the exact same time, you are fully prepared to take over the airway if it starts to fail. And this whole case leaves us with a really important question, doesn't it? In any crisis, how do you know when to fight the fire, the underlying cause, versus when you need to manage the smoke, the immediate life-threatening symptom? Knowing the difference, that's what saves lives.